This video introduces Chapter 13 of OEC 6, Respiratory Emergencies, and focuses on the anatomy and physiology. Our objectives are to describe the physiology of breathing and identify the primary muscle of ventilation, and then look at the normal respiratory rate for individuals in different age groups. We'll encounter a few of these key terms during this presentation. Ski patrollers, OEC technicians, may encounter patients with abnormal breathing, which could range from exercise-induced asthma to airway obstruction to severe respiratory distress. We may have respiratory emergencies associated with other medical conditions, such as a heart attack, too. Look at it this way. Every one of us on the planet has 4 minutes to live. Every time you take a breath, you reset the clock. The oxygen supply to our brain cannot be interrupted for more than 4 minutes without severe consequences. What we can do as OEC technicians is perform a thorough assessment, identify life threats, and initiate therapies including oxygen before transporting our patient to higher care. In this chapter, we review the anatomy and physiology associated with respiratory emergencies and discuss the common types of respiratory emergencies you may encounter, their signs and symptoms, and the management. Let's focus on anatomy and physiology. Ventilation is the mechanical and physiological mechanism by which we take a breath. So we look at the structures of the upper airway beginning at the mouth and nose, through the pharynx, and stopping at the larynx or the voice box, and then consider the lower airway as well, being the trachea branching into the bronchi and bronchioles and terminating with the alveoli. Air that we breathe is 78% nitrogen, 21% oxygen that our body uses, and 1% other gases such as CO2 or argon. Now, gas exchange at the alveolar level is driven by a high concentration of oxygen in the air and a low concentration of carbon dioxide in the air. So what we have is diffusion. We have the gas that we need, oxygen, moving from high concentration in the air into the lower concentration in our bloodstream. We accomplish that with the high surface area in the alveoli. That's where the gas exchange occurs, and we have about 700 million alveoli in the lungs. High surface area due to their highly irregular structure. By diffusion, oxygen at high concentration in the air will cross across that barrier into the very fine capillaries that are associated with that. And at the same time, a high concentration of carbon dioxide being returned from the body will also allow for diffusion from the capillaries back in to the alveoli and allow for exhalation. Now, carbonic acid is also going to be part of that system, and it's going to be what drives our respiratory rate and depth. Why? Because carbon dioxide can react with the water in the blood and it makes carbonic acid. Our blood becomes more acidic, that is, it has a lower pH. Excessive CO2 in the blood is detected by sensors in the carotid arteries, and so this high carbonic acid that results as CO2 reacts with water gives a lower pH, a more acidic bloodstream, and that's going to signal our brain to increase both the respiratory rate and the depth of our breathing and let us blow off excess CO2. Our pH will return closer to normal, closer to a neutral 7. Therefore, it's the amount of CO2 in the blood that actually controls our breathing, not the amount of oxygen. Now, any disruption caused by that is what we call difficult breathing. We have dyspnea. The prefix dysp means difficult or painful, and then of course the same root word as we see in pneumatics, for example, breathing. So the two phases mechanically of respiration are inhalation and exhalation. And so we get contraction or shortening of the diaphragm. And if we contract the diaphragm, what happens is we end up with expansion of the lungs. That allows air to move from the outside space at a high pressure into this larger space we've created by contraction of the diaphragm. During exhalation, the diaphragm relaxes, it extends, and it lengthens, and therefore air is going to be pushed to the outside. Now we can consider what normal breathing looks like, and we can look for four things: rate, rhythm, quality, and depth. One of our key objectives is to remember the normal respiratory rates for different age groups. Adult patients typically breathe about 12 to 20 times per minute. That is, if you consider it, maybe about once every 5 to once every 3 seconds if we look at that range. For children and infants, the normal respiratory rate increases so that for an infant, anywhere between once every 3 seconds to once every second can be considered normal. When we consider rhythm, we should be looking for breaths of equal duration in terms of time. And when we look for quality, we should produce very little external sound. If we have an obstruction, we may hear wheezing, for example. And then finally, depth, the amount of air taken in for each breath. And we may look additionally at how the chest expands, and if we incorporate accessory muscles beyond the diaphragm, this may be an indication of labored breathing.